Low back pain is extremely common. We're going to use this as an example of how all of the massage applications with assessment combine together to provide a targeted outcome-based treatment. As demonstrated, I'm moving my hand underneath the lordotic area, which also indicates that the psoas is short. I'm also checking to identify if the pelvis is rotated and looking at distortion patterns for internal rotation of the leg. The client has a bilateral anterior rotation, which results in a lordosis. The tissues in this area are going to be short and binding. Additional assessment is provided for the SI joint. In general, compression to this area will increase the symptoms if the SI joint is involved. Compression bilaterally on both sides of the spine will increase psoas tension and indicate if that is a contributing factor. And only on one side at a time would indicate quadratus lumborum. The client is showing where the pain area is. This particular patient has combined sacroiliac joint issues, quadratus lumborum, shortening and referred pain patterns, and psoas shortening and referred pain patterns. Muscle activation sequences, especially firing patterns for the hip and abdominal area, are going to be distorted. Placing bolsters under the knees will reduce the lordotic curve. Using the psoas release techniques, we're going to begin to address this issue. Compression for the psoas proceeds down through the abdomen and can be specifically identified when the client moves their leg. Then inhibitory pressure is provided. Next, the anterior rotation of the pelvis will be addressed with indirect functional technique. In this instance, an anterior rotation results in taking the leg and placing it so that the pelvis is in more of an anterior rotation, and then encouraging it into posterior rotation. The patient is moving their leg against resistance, and then at the end of the range, the joint is moved into a posterior rotation. The area is reassessed. Quite often, other distortions will show. In this instance, after correction for anterior rotation, an inflare was identified. Again, indirect techniques will be used. Exaggerate the distortion, have the patient push out. After 2 or 3 repetitions, then allow the leg to move in the opposite direction to correct the pelvis position. Provide just a little overpressure at the end of the range. Make sure to stabilize. Constantly reassess to identify for progress. By having the clients push their knees together against a resisting force, it settles or stabilizes the pelvis. Next, the quadratus lumborum release is used. If it is more comfortable for the patient, this position for working with the psoas can be used. This third alternate position for the psoas release is one of the most easy to do. With the patient in the side-lying position, it's easy to manipulate the leg and utilize muscle energy techniques. The psoas muscle can be stretched in the side-lying position. Caution is required if there's any kind of disc involvement. By palpating for the specific attachment area of the psoas, or the area where it crosses the symphysis pubis, you can isolate the stretching action. With the client prone, specific application to the SI joint can begin. Compression against the sacrum gaps the SI joint, and then as the client moves their legs back and forth, they are able to provide movement into that area. There are two kinds of stability at the SI joint: form stability, provided by the shape of the bones, and force stability by the muscles that cross the joint. With the sacrum distracted and the client moves as if walking backwards, we're beginning to address force stability. Muscle testing is used to identify if the issue with the SI joint is more form, about the bones, or more about the muscles. If when the arm is brought into the muscle testing procedure, it's easier to hold the leg up, then the muscles are involved. With the knee bent, you should see a 45-degree movement internally and externally. If that is not the case, pressure into the deep lateral hip rotators may help. This can be either an active, passive, or active resisted movement. Again, supine, we're reassessing to see what has been accomplished. The lordotic curve has reduced. The anterior rotation has improved. The legs move rhythmically. There still appears to be an internal rotation. Using the integrated muscle energy technique, which is an indirect method, we are going to increase the distortion and have the client push or pull out of that. What this accomplishes is a tensing and therefore a strengthening of the muscles that are inhibited, reciprocal inhibition to the muscles that are short, and then specific stretch to the area can be applied. By applying stabilization and finding the binding area, the method of pin and stretch can be incorporated. Whenever working with a specific condition, you only need to have about 15 minutes of focus at the most. These methods would have been incorporated into the full body sequence.